Welcome to AETCM, the emergency medicine channel. Today, let us discuss about thrombotic thrombocytopenic purpura. Here, there are two important problems. One is thrombosis forming inside our blood vessel, and that will lead to consumption of platelets, and it may lead to thrombocytopenia. Then it will produce bleeding tendency. That is thrombotic thrombocytopenic purpura. When we discuss about blood vessel wall disorders, there are three important vessel wall disorders. So all these three conditions, the problem is in the vessel wall. The presentation may vary, but the problem is basically in the vessel wall. TTP, hemolytic uremic syndrome, Hinoch-Schönlein purpura or anaphylactoid purpura. In this, Hinoch-Schönlein purpura is a benign condition where you get only lower limb purpuric rashes. Very rarely they have systemic manifestations. Otherwise, it is confined to only skin. It's a benign condition. Whereas TTP and HUS are very dangerous conditions. They come to emergency room with thrombocytopenia, bleeding tendencies, shock, renal failure, neurological abnormalities, all these things. TTP is initiated by endothelial injury, so it's a blood vessel problem with subsequent release of von Willebrand factor and other procoagulant materials. It leads to thrombotic microangiopathy. It causes a severe reduction in the activity of von Willebrand factor cleaving protease Adams 13. So the deficiency of this protein, that is a major reason, whether it is acquired or congenital, the deficiency of this Adams 13 protein is very protease in cleaving protease is very important. It is characterized by platelet rich thrombi in the vessel wall that leads to consumption thrombocytopenia and microangiopathic hemolytic anemia. They are not immune mediated. Sometimes it may lead to organ damage also. It can be acquired, so there will be an antibody inhibitor, antibody against Adams 13, or hereditary, that is mutation in Adams 13 protein. So Adams 13 is a disintegrin and metalloprotease with thrombospondin type 1 motif member 13. So that is a protein which is very needed for von Willebrand factor. It's primarily synthesized in liver, and its main function is to cleave von Willebrand factor. It is seen in the endothelial surface, and it can be in circulation also. And wherever there is a vascular injury, it will go and act there, and that produces the vessel wall injury. Can be for treatment of vessel wall injury, it is useful. Deficiency of plasma Adams 13 activity less than 10% resulting in mutations of Adams 13 gene or antibodies against Adams 13 causes hereditary or acquired TTP. Now, deficiency of von Willebrand factor cleaving protease, that is Adams 13, is a main cause for platelet thrombosis in TTP. In acquired TTP, the cause is due to antibodies which blocks Adams 13. In hereditary, it is due to the deficiency of Adams 13. So that will lead to, the deficiency will lead to platelet aggregation. You can see in the picture, the deficiency can lead to platelet aggregation and thrombus formation. So this large amount of thrombus formation will reduce the platelet count by consumption of platelets for the thrombus. So Adams 13 levels can be very low during acute phase of this TTP, less than 10%. But this test is not available in everywhere. Normally in routine hospitals this test is not available, but severe deficiency can be diagnosed by that Adams 13 activity less than 10%. So this deficiency of Adams 13 or TTP can produce microvascular deposition of hyaline fibrin thrombi in the arterial wall and various organs. Microangiopathic hemolytic anemia, that is Coombs negative, that means it is not immune mediated, and it leads to hemoglobinuria. So your urine will be cola colored. Whenever platelets are low, whatever may be the reason, whether it is ITP, dengue or TTP, patient develops purpuric rashes all over the body. Whereas you have seen henoch-Schwann purpura in the first slide, that's also a type of vessel wall disease. There the purpuric rashes are only in the lower limb. Patient can have fever. Many patients will have renal failure. Fluctuating levels of consciousness, delirium, seizures, neurological deficits can also be there in some patients. GI symptoms are common in acquired TTP like abdominal pain, nausea, vomiting, diarrhea can be there. So this is a pentad of TTP. Patient can have fever. Patient can have thrombosis and thrombocytopenia. Some patients can have renal failure. Some patients can have neurological findings like seizures, altered mental status. Then many patients can have non-immune mediated microangiopathic hemolytic anemia that can produce anemia, jaundice, elevated LDH, elevated bilirubin. Now we will see what are the causes for acquired TTP: pregnancy, cancers, chemotherapy, HIV infection, antiplatelet drugs, infections like sepsis, autoimmune diseases, vasculitis, and many other immune mediated conditions also can lead to TTP. Now, whenever we get TTP, whether it is TTP, ITP or DIC, whatever it is, we routinely do one plate complete blood count. Complete blood count, you can see hemoglobin that is reduced here. Here it is reduced because of hemolytic anemia. Then platelets are reduced because it is the condition produces thrombus and consumption of platelets that produces thrombocytopenia. WBC can be slightly elevated if it is due to infections. Now, other investigation which shows there is hemolytic anemia, that is elevated LDH, elevated indirect hyperbilirubinemia, and SGOT, SGPT may be normal. Many patients can have elevated blood urea nitrogen or urea. Creatinine also can be elevated. Many patients also can have proteinuria. ANA positivity can be seen in 20% of the cases. ANA and dsDNA positivity indicates SLE-like diseases. So Adams 13 levels can be checked in suspected TTP. That is done by specialized labs. If it is the levels are less than 10%, it's a severe deficiency. Patient may develop bleeding tendency because of this. Now, peripheral smear gives an important clue whether the patient is having hemolytic anemia or not. If there is hemolytic anemia, you can see schistocytes. You can see here partially damaged blood cells, RBCs. They are called as schistocytes. So, or you can also see young RBCs, nucleated RBCs. All these things are due to overproduction of RBCs from the marrow. So, platelet count can also be low. Platelet clumping also can be seen in peripheral blood smear. Now, there is an important differential diagnosis for TTP, that is HUS. It's a condition affecting the blood vessels, same we have seen in the first slide, and it produces arterial and capillary microthrombi and thrombotic angiopathy. It results destruction of platelets, that is thrombocytopenia, low RBC, Coombs negative hemolytic anemia, and renal failure due to damage for very small blood vessels in the arteries. So HUS is mainly due to infection, like abdominal infection or urinary infection that mainly occurs in the younger children. So you can see the differentiating features of TTP and HUS here. Microangiopathic hemolytic anemia is seen in both the conditions. Thrombocytopenia seen in all patients with TTP, so most of the patients in HUS. And fever is a classical finding seen in TTP, not seen in HUS. But many patients with HUS will have a past history of fever, that we should remember. Renal failure, mild and it will be mild renal failure. Many patients it will be absent also. There may not be any renal failure. Whereas HUS, hemolytic uremic syndrome. It is uremic syndrome. So renal failure is almost always associated with HUS, but very rarely seen in TTP. Whereas neurological deficits like loss of consciousness, low GCS, seizures, focal neurological deficits, all are feature of TTP, but HUS it is very rare. Age, TTP is very common in adult patients or elderly individuals. HUS is mostly seen in children. You can see here another differential diagnosis is disseminated intravascular coagulation. There are also differentiating features. You can see DIC and TTP. Pathogenesis is endothelial defect in TTP. DIC, it is a thrombin production. Clinical condition, a patient is very ill. DIC also very ill. Red cells, schistocytes are seen in peripheral smear. DIC also you can see that. PT-INR is elevated in DIC. APTT is elevated in DIC. Fibrinogen levels are low in DIC. That is a classical difference between TTP and DIC. PT-INR is elevated in DIC, APTT is elevated in DIC, and fibrinogen levels are low in DIC, but that is not a feature of TTP or ITP. ITP is immune thrombocytopenic purpura. D-dimer is also increased in DIC. Management, you can see here plasma exchange is the management for TTP. DIC, it is supportive and antibiotics or whatever it is. We'll see next slides. One of the most important treatment for TTP is plasmapheresis. Don't think that in this condition platelets are low and if you give platelets patient will improve. Patient may deteriorate even with platelet transfusion. So we have to be very careful in TTP. Once you diagnose TTP, avoid platelet transfusion unless until it is a life-threatening condition, like somebody is having a bleeding inside the brain or intracranial hemorrhage that is due to very low platelet. To save the patient, you can give platelet during that time. Otherwise, it produces more damage to the patient because whenever we give platelet, it produces more thrombus formation inside the circulation. So we don't routinely advise platelet transfusion in any patients who is having TTP. Plasmapheresis is the treatment of choice. Plasmapheresis or plasma exchange. Usually at least 5 plasma exchanges, 60 to 80 ml per kg plasma should be removed and replaced. Fresh plasma should be replaced. So you can remove 60 to 80 ml per kg plasma from the patient's body that is having defective proteins and defective coagulation materials. So that will be removed and you replace with normal person's plasma so that patient can improve. So Adams 13 can be replaced by plasma exchange. Plasma contains Adams 13 protein. Usually 5 plasma exchanges performed first 10 days. If no response, exchange should be repeated. Another 5 can be given. Cryo-poor plasma or cryo-supernatant plasma also can be given if the patient does not show any improvement with plasma exchange. Most of the patients who is having thrombocytopenia in TTP, platelet transfusion is contraindicated, or in a dire condition only you should give platelet transfusion. Otherwise, like you can see in DIC we give platelet transfusion, ITP we give platelet transfusion, HUS also we may require platelet transfusion depending on the platelet levels. But this is one condition where the platelets are very low, but we don't give platelet transfusion because if you give platelet transfusion, these platelets also can produce thrombi formation in the blood vessels. So plasmapheresis means take out the plasma, 60 to 80 ml per kg body weight plasma is removed from the patient's body. That much plasma is given back to the patient that contains Adams 13 protein. That improves the clinical condition, that prevents the aggregation of platelet and thrombocytopenia. So that is very important. Plasmapheresis is the treatment of choice, not platelet transfusion. Other drugs, like since we know that some of these TTP are due to immune mediated. There we can use steroids. Like if there is an autoimmune disorder which shows inhibitory antibody to platelet factors, then you can use steroids. Normally we can give steroids in pulse therapy. That means prednisolone or one prednisolone 1 gram per day into 3 days we can give. Methylprednisolone 1 gram into 3 days we can give. Or if the patient is stable, we can give prednisolone 1 milligram per kg body. That means suppose 70 kg patient is admitted with TTP. If she is very sick, you give 1 gram methylprednisolone into 3 days. After that, 1 milligram per kg body weight prednisolone. That means 70 milligram prednisolone should be started for that patient. That prevents the antibody formation, and von Willebrand factor cleaving protease can be produced by inhibiting the antibodies against this von Willebrand factor. Another drug which can be used instead of steroid, that is rituximab. That is a very safe immune modulator comparing with steroids, but it is costlier than steroids. So rituximab is a monoclonal antibody that targets CD20 antigen present on B lymphocyte cells. So that also reduces the antibody formation from the B cells. So if there is a refractory TTP, or if the patient does not improve, or if there is adverse effects due to steroids, or patient is affordable, you can go for rituximab. That gives better results than steroids because the side effect profile is better than steroids. N-acetylcysteine is an experimental drug that also can be given in patients who are saying TTP, but it's not a definitive drug. So another new drug, that is caplacizumab, that can be given in patients with anti-von Willebrand factor monoclonal antibody. So dose is subcutaneous 11 mg IV at least 15 minutes prior to plasma exchange, followed by 11 mg subcutaneous after completion of plasma exchange 1 to 30 days. Now platelet transfusions, we already discussed platelet transfusions are not very safe in TTP, because even if we give platelet, we know that a transfused platelet may only stay in your body for 24 hours. A normal platelet in our body lives for 7 days, but a transfused platelet may live only 24 hours in the body. So in any condition who is having thrombocytopenia, only if there is an emergency is seen, then only we have to give platelet transfusion. Otherwise, unnecessarily giving platelet transfusion for preventive purpose, it is not safe, because whenever we are transfusing, there is a risk for transfusion reaction. So if it is really indicated, unlike blood can be given, like, because even if you transfuse blood in anemia, it may live, the RBC may live for another 60 to 120 days, but platelets in our body, transfused platelets live only for 24 hours. That too in TTP, that will be immediately destroyed. That transfused platelets will form more thrombus and more problem. So unless until there is an emergency, we are not going to transfuse platelets. Here the treatment of choice is plasma exchange and give adequate Adams 13 through this plasma exchange, or steroids, which reduces the antibodies which is formed against Adams 13. So one of the important conditions that we always remember, one of the important condition which can produce thrombocytopenia, TTP, HUS, DIC, all are sepsis. So the major problem behind all these things is infection, especially gram-negative infection, and that too in infection in urine or abdomen. So we have to be very careful when we are treating this type of diseases. Most of these patients will have some infection. So better to treat the infection in all these conditions, because unless until you treat the infection, patient will not improve, because continuously there will be antigen stimulation by this antibody stimulation against this bacteria or virus, whatever it is. that antibodies can act against this Adams 13 and the levels of Adams 13 will come down and thrombus will be formed. Like any other immune mediated disease, here also the problem is immune mediated destruction of Adams 13 that produces more platelet aggregation, that produces more consumption of thrombus, more consumption of platelets, and continuous platelet aggregation, destruction, utilization, that all ultimately leads to very low levels of platelets and patient can bleed. But if you see DIC, there the problem is different, but there also patient is going to bleed. There microthrombiforms, PT, APTT both are elevated, fibrinogen is very low because that is utilized, then patient develops bleeding. So whatever condition we are seeing here, many of these patients can have thrombus formation in the heart or brain. It can lead to myocardial infarction or stroke. So there will be one important question will be asked by the physician, whether we can treat the patient who is in myocardial infarction, whether we can treat with aspirin, whether we can treat heparin. All these things are very important, but the answer is yes. If there is a definitive indication for aspirin, suppose the patient is having platelet counts are slightly low and during the TTP patient has developed myocardial infarction, if required we have to give platelets, because the problem here is not platelet dysfunction, it is only thrombus formation, platelet aggregation. Aspirin can prevent some of the platelet aggregation, so it may clinically improve the patient and clinically improve the myocardial infarction. Like DIC, whether we can give heparin or not, heparin should be given in early phases of DIC, but late phases, once the patient develops bleeding and all, it will be very difficult. HUS, the treatment of choice is mainly antibiotics. Thank you.